Cesar Victora is Emeritus Professor of Epidemiology at the Federal University of Pelotas in Brazil, where he works since 1977. He also has honorary appointments at Johns Hopkins University, the London School of Hygiene and Tropical Medicine, and Oxford University. He has conducted extensive research in maternal and child health and nutrition, birth cohort studies, inequalities in health, and on the evaluation of the impact of major global health programs. Cesar was one of the coordinators of the Lancet Bellagio's Child Survival series, and in 2008 and 2013 of the 2 Lancet series on maternal and child nutrition. He's one of the founding members and current scientific coordinator of the Countdown to 2015 Maternal, Newborn, and Child Health Initiative, aimed at monitoring the Millennium Development Goals for mothers and children. At the Federal University of Pelotas, he coordinates the International Center for Equity in Health, has over 500 peer-reviewed publications, and is a member of editorial boards of several journals, including The Lancet. He's a past president of the International Epidemiological Association.
Can you hear
Welcome.
me?
Yes, perfectly.
Thank you very much. Okay, so let's move on and address this complex topic that you have asked me to address, which is social inequalities in maternal and child health, global patterns and trends. And I'm going to move on right to the next slide, in which I will take a more focused look at this topic by looking at whether equity is improving in child health around the world. Eduardo, I think you have to silence your microphone. Okay, good.
I just did that.
Okay, perfect. So I'm moving on, and I'm going to tell you a little bit of what I do these days. And we have a small group of people whose pictures are here, who are the International Center for Equity in Health at the University of Pelotas in Brazil, a very remote part of the country, almost outside Brazil at the border with Uruguay, and where we do a number of analyses that we're going to be describing to you during this talk. We do 3 things. We have a global observatory for inequalities in maternal health. We have a huge database, and we do dissemination in terms of monitoring and accountability, holding countries and institutions accountable for progress or for lack of progress in improving maternal and child health. And we do scientific research. So we publish papers on patterns, trends, determinants, and forecasting future trends. So I'm going to give you a little bit of information about each of the 3 circles or ovals in this graph, so that you can interpret our results in the light of what we do. We know that the Millennium Development Goals are finishing. They are finishing very soon, and our work has been inspired by the launch of these goals in 2000. Their baseline is 1990, but they were actually launched in 2000. And we're particularly interested in the first Millennium Development Goals, which is about ending poverty and hunger, where we look at indicators of undernutrition in children. We are interested in the 4th goal, which is to reduce under 5 mortality by 2/3. And we are looking at the 5th goal, maternal mortality reduction by 3/4. We don't really look at MDG 6, which is HIV, AIDS, TB, malaria, but we do have some variables related to these infectious diseases in our database. So we do a little bit of work on that, but our real focus is on MDG 4 and 5 and on child nutrition, which is part of MDG 1. We know that the goals are finishing now. We know that very few countries will reach MDG 5, maybe half a dozen countries among all low and middle income countries. Of reducing maternal mortality. We know that about a 1/3 of the countries will reach MDG 4, given the current statistics that we have. So it was mostly a story of things that didn't work that well in many countries, but there's also very good positive stories of reaching the goals and improving equity, as we'll see later during the talk. In the MDGs, there's no mention to equity. There's nothing about equity. So if a country reached a 2/3 reduction in mortality of children, but if given ethnic groups like the indigenous populations of Brazil, or the African or Brazilian Americans, or African Brazilians, are not reached, that doesn't matter for the goals. The goals were national, so it's a great opportunity was missed in 2000 to include an equity component in the goals. But having said that, we, as Eduardo mentioned briefly when he introduced me, I was one of the coordinators of this series of papers that came out in 2003. It's called the Lancet Child Survival Series, which became very influential. We're very happy about that. And the paper that I led in the series was the 4th paper in the series. We named it, it was entitled Applying an Equity Lens to Child Health and Mortality. More of the same is not enough. That is, just to keep monitoring national trends without looking at the poor, without looking at the blacks in Brazil, for example, or the indigenous populations, is not enough to let us know how well the country is doing. The national averages hide very important disparities. So we, in the last paper in that series, we said we commit ourselves to have a meeting every 2 years to take stock of progress. It's an accountability approach. We want to see how well the world is doing in terms of reaching the goals, and also not only reaching the goals at national level, but also reaching population subgroups defined on terms of a number of the disaggregated analysis. So the countdown to 2015 was born when we had this paper in 2003. It's a multi-stakeholder initiative. Every 2 years we have reports. It includes universities like the University of Pelotas, but it also includes Harvard, Hopkins, the London School of Hygiene. We include institutions in several countries. It also includes the UNICEF, the World Health Organization, the Bill and Melinda Gates Foundation, the World Bank, and so forth. It has 42 different institutions now are part of the countdown. But the important thing is that the countdown is led by scientists, by academics who are independent from these agencies. So the agencies are part of the group, but we lead the work. You know, a handful of scientists are leading this work, have led this work for the last 10 years. We actually had our first meeting in 2005 in London, and we're having our last one now in Mexico next month. And every 2 years we launch this report. You can see our web page there. If you want to go in there and see our documentation, country by country data, you're very welcome to come and visit and let us know what you feel about the results that we share in that web page. The heart of the countdown is to be user-friendly. So we have to present complicated data in a simple way so that our primary target audiences is not a scientific audience. It's an audience of policymakers, health managers, health workers, and the population in general. So for each country, and here we have Malawi on the screen, we have a 2-page country profile that we update every year. In fact, our report comes out every 2 years, but the profiles are updated every year. And it has information on mortality trends, it has information on causes of death, on nutrition, but mainly on intervention coverage. We are very, very keen to check whether the life-saving interventions like treatment for diarrhea or for pneumonia or for malaria, and the vaccines and antenatal care and skilled care at the birth, whether they are reaching all the different groups of the population. And I'm going to tell you a bit more what our group in Pelotas does in that, but we are one of the leading institutions in this. We also do the Global Health Observatory of WHO. If you go to the Global Health Observatory, you find a tab for the Health Equity Monitor, which includes analysis, disaggregated analysis by wealth, by education of the mother, urban, rural, by sex of the child, and so on, for a large number of variables. This part of the it's part of the World Health Organization website. It's an observatory that is led by WHO, but all the analysis of equity are done by our group in Pelotas. So we do contribute to that effort as well. That's why what I mean by dissemination. It's our emphasis on disseminating results. And then very important, perhaps the most important thing, is to have country-level dissemination. So we prepare profiles for the countries, as I showed you before, and then we also show special profiles on, for example, this one is for Nigeria, and we took 8 interventions that have been around for a long time. So every mother and child should have antenatal care, skilled assistant delivery, we should have basic vaccines, should have safe water, and so on. And then we look at those who are excluded, being left behind. I have to remind you, and I'll come back to that later, that we do not collect the data. We don't do these surveys, but we take existing surveys and we reanalyze them with an equity lens. So if you look at the children, for example, in Nigeria, 18% of them have not received any of the 8 interventions. And these are very, very basic interventions. We're not talking about sophisticated treatment or vaccines. These are basic things like a DPT vaccine and like antenatal care. So 18% don't get that. But of those who don't get it, 59% are in the poorest quintile of wealth. So 20% of the population represent 59% of the children and mothers who do not get these basic life-saving interventions. Very compelling direct example of how we should do research, but we have to worry about translating this research so that people who are not highly technical, who don't have a PhD in epidemiology or statistics, can understand and grasp them. So this is one of our major efforts, is dissemination at country levels through infographics, such as the one you see for Nigeria on this page. But let's move on. How do we do this? You know, what kind of data do we use? Well, the last time we counted, we had analyzed 268 surveys. I know it's more now, it's more like 280 from about 100 countries, because a lot of these countries carry surveys with support from different agencies, from UNICEF, for example, which carries out the MICS surveys, MICS, multiple indicator cluster surveys, which I helped develop in 1994, and now it's being used in over 70 countries in the world. USAID has an important initiative for surveys called the Demographic and Health Surveys, or DHS. Brazil has had a couple of those, and it's a real shame that the last one in Brazil was carried out in 2006, 2007. We are worse off than most countries in the world because we don't have national maternal and child health surveys. But that's a parenthesis. Let me get back. So we have over 6 million children in our database. We have over 3 million women. And we have reanalyzed all these surveys, mainly with the help of my colleague Aloysio Barros. And we have all recoded all the surveys in a similar format. So we can do a batch analysis now. We can, if we want to know what is the association between, say, maternal education and vaccination status in 100 countries, we can run, in a single run, we can run all the analysis. It takes a little while because our computers are not that fast. But overnight, if we do it on one day, next day we get the results for 100 countries. We don't have to do it country by country. All the data sets have been recoded and reformatted so that it allows analysis in batch mode. And we do all the equity analysis. We do summary equity indices like concentration index or slope index. We have standard errors for all these estimates and so on. So this is the database that we handle. We're constantly updating it. Every year we add 20 or 30 surveys that become available. So this is our data. And then we can do global level analysis. And this kind of chart, I just want to take a minute or two to show you what this chart is. This chart is called an equiplot. If you want to draw one, visit our website in Pelotas and you can download the do file in Stata that will do these graphs. And we have 5 circles. The dark circles are the poorest 20% of the families. And the golden colored circles, and that was an idea of someone in our group, rich wealth is gold, so let's have the rich in golden colors. And then this is global averages. These are about 88 different countries. And you look at the interventions and you see the distance between the dark and the gold circle represents inequality. So if you look at breastfeeding, for example, 1, 2, 3, 4, 5 lines down from the top, there's almost no inequality. Different people, different groups breastfeed. Similarly, if anything, the poor breastfeed a little bit more than the rich, but that's a real exception. Every other intervention we look at, and I only have 7 interventions in this chart where we do this for over 70 interventions, you see that the rich do much better than the poor on the overall level. The most unequal or inequitable intervention of all is consistently a skilled birth attendant, that is giving birth to a child in a place where you have somebody who's trained. Could be a doctor, could be a trained nurse, could be a trained midwife, but you go to an institution and you deliver your baby there. That's the most unequal because it costs money, and many places don't have such institutions. So we have huge gaps there. Let's go down the line to second from the bottom, DPT vaccine. That's quite equitable. Still, the rich are more vaccinated than the poor, but it's quite equitable because it's usually delivered through campaigns or at the community level, at the village level in Africa or Asia. So we get better equity if the intervention comes to the families rather than if the families have to come to an intervention center and pay for it, which is the case of skilled birth attendant and antenatal care. This is just an example. We have lots of publications and papers in which we address these issues in more detail, but I just wanted to call you in to go through this graph with you because most of the following slides are using the same kind of graph and to address changes in equity. So the question that I'll try to answer in the next 20 minutes or so is equity improving? And the answer is it depends. It depends on the country or region of the world. It depends on the time frame, how long you monitor equity for. It depending on the stratifier that you use. Is it wealth? Is it education? Is it urban or rural residence? It depends on the outcome. Is it skilled birth attendant or vaccines? And also, it depends on the scale that you're using. Are you using an absolute or relative scale to monitor equity? And I'm going to explain a bit more about these scales later because it's a very important issue in equity epidemiology or in epidemiology of analysis of inequalities. So let's go and focus on wealth quintiles. So we basically, wealth quintiles are derived from an asset index. An asset index is going to a home and observing whether people have, what kind of construction they have, what kind of floor, what kind of walls, what kind of roof, whether they have a radio or a television set or a bicycle, and a number of household possessions that indicate how rich a person is. It's very, very useful. It's simple to measure and very reliable. We have used it in many, many countries with very concrete and results that have a lot of face validity. That is, the results come out in the way you expect them to be. It's a very simple way because you asking about income, for example, in a rural society, it's very complicated. Sometimes people hardly have any income. They produce their food, they sell part of the food, they eat the rest. But the asset index reflects very closely how wealthy they are. So let's move on with the wealth quintiles. I mean, there are other dimensions to inequality, but I'm just going to focus on wealth quintiles now. And then we have the issue of absolute and relative inequalities. And we have simple measures and we have complex measures. And I think it's very important for us to have both sets of measures. We use simple measures to be able to disseminate our results, but complex measures also have their advantages in terms of the statistical and epidemiological validity. And then we have absolute and relative measures. So let's look at the absolute measures. Now, the simple measure is the difference between the richest and the poorest quintile. So the richest quintile has a vaccine coverage of 82%, and the poorest have a vaccine coverage of 62%, and then the difference is 20 percent points. So absolute is always expressed in percent points, not in percentages, okay? These are different things. If you go to a relative measure, and the simple measure is the ratio, divide the poorest by the richest, or the richest by the poorest, doesn't matter, depending on the indicator. So you just divide one by the other, and you can say, oh, coverage in the rich is 1.5 times greater than the poor. But then for each of these two simple measures, we have a more complex measure. For the absolute measure is the slope index of inequality, which is a regression line that is fitted through the 5 quintiles and takes into account the whole distribution, not only the rich and the poor. So that's a real advantage. And then we have the concentration index for the relative measure, which is a bit more complicated to calculate. It was derived by economists, and it basically, it's a kind of a Gini index. It's an improvement upon the Gini index by using coverage, for example, with an intervention against wealth, and doing the cumulative proportion of coverage according to wealth, and then you calculate how much inequality there is. I don't have a lot of time to discuss these, but if you're interested in equity in health, there are a number of papers. You can look for papers authored by Aloysio Barros and myself, and you'll find a detailed definition of these indices. So let's move on, and I'm going to tell you a little bit about the Pelotas cohort, very little, just because I want to show you some examples of the differences between absolute and relative inequalities. And we now have 4 population-based cohorts. Each one has all the births in the city, started in 1982, and the latest one is underway now. We're collecting data for the 2015 birth cohort. And when we did our first book in 1988, I think, we called it Epidemiology da Desigualdade, Epidemiology of Inequality, because it is the most striking thing for us is when we did the 1982 cohort, we found that infant mortality, which was one of our key indicators, was 12 per thousand among the rich and 80 per thousand among the poor in the same city. So that was really striking, a 7-fold difference. And we decided to name our book Epidemiology of Inequality. So we're still going on with the cohorts, but here's just a quick example of the what I just showed you before. This is from our book. We cut and pasted from the book, so you see the old style slides. There were no PowerPoint in those days. We had to draw these slides by hand. And if you look at the poorest, let's look at the black bars first. You look at the poorest I just mentioned, 80 per thousand, and let me just use the arrow here. I hope it works. Okay, 80 per thousand in the poorest, less than 1 minimum wage, and 13 per thousand in the richest in 1982. In 1993, there was a big reduction in the poorest, from 80 to 33, and in the rich, from 13, it went down to 5. So if I look at the difference here, I can show you that the difference was 67 deaths per thousand in 82, 80 minus 13. It was 28 deaths per thousand in 1993. So if you look at that, your conclusion is equity improved. And it's true. It's a true conclusion. If you look on absolute terms, absolute being defined in terms of deaths per thousand, there was definitely an improvement in equity. However, if you look at the ratio, if you divide 80 by 13, and if you divide 33 by 5, you get that equity remained about the same. Maybe, perhaps, a little bit worse. The poor was 6.2 times more likely to die than the rich in 82, and now they are 6.6 times. Not now, but in 1993. So this is just to illustrate the issue that the relative and absolute scales may give you different answers. And it's a very complicated issue. It's not a straightforward issue. And there's a great paper here by John Lynch from Australia, who's Karen's colleague, and Sam Harper is the first author, on the issue that there's not a single answer. There are value judgments in measuring health inequalities. You can just as easily say that in Pelotas, inequality got better on absolute terms, but did not improve in relative terms, and both are true. They just depend on the scale of measurement. And this is true for many other things too. But the key issue here is that some sort of value judgment. As epidemiologists, I always like relative measures because you know epidemiologists, they cannot resist the temptation of dividing one number by another. Whenever you have two numbers, you divide one by the other. And that's the whole thing. You have divide cases by population, and then you divide prevalence in exposed against prevalence in unexposed. So we're always dividing. And for many years, I thought, relative is the truth. But now I'm becoming maybe older and more interested in policy, and I think absolute has a lot of value as well, if not more. It's easier to transmit the idea that 67 of each 1,000 children are not dying now than they were before. It's a more concrete measure than say, oh, we have a rate ratio of 6.2 or 6.6. So both have value, and we should basically report both. But I think from a policy standpoint, from a public health standpoint, the absolute measure has a lot of value as well. Not only the relative measure is important. So the absolute measure gives you an idea of the real distance. You have two countries in one. In Brazil, we had a country where 67 out of each 1,000 children were more likely to die if they were poor than if they were rich. It also gives you an idea of the effort that would be involved. How much would you have to work to prevent those 67 unnecessary deaths? And then the relative measure gives you a different idea. It's a measure of fairness, 6 times more likely or 7 times more likely. So it's also useful, but in a different dimension. For this reason, all of us now work in equity field feel that it's important to look at both absolute and relative. If you get the same results, the same trends, then you can only present one of them. But it's also important to look at both when you're starting. So let's try to answer my question. I have 15 minutes now or less. So let me show you 4 indicators that we use. We're looking at coverage. In the coverage, I'm going to show you what kind of indicator we're using. It's a composite index. We're looking at fertility, we're looking at mortality, and we're looking at stunting. Stunting is the deficit in height or length for age. Children who are not growing according to what we would expect they would be growing for a number of reasons. Nutritional reasons, but also infections, quality of care, and so on. So let's move on. And there's a lot of talk about the universal coverage now, and I'm not going to go into the political discussion here, but it is useful to have a measure that shows coverage in general. And by coverage, I mean the percent of those in a population who need an intervention who actually get it. So for vaccines, everybody needs an intervention. Every child needs intervention. So you just calculate how many get it. But for diarrhea treatment, for example, you only have children who have diarrhea in the past 2 weeks, for example, and were asked about it in a survey. So the coverage is a proportion who get an intervention out of all of those who need it. And we came up with this idea in the countdown that we needed a weighted average to reflect 4 stages in the continuum of care. Continuum of care, we mean from a woman in reproductive age to get pregnant, to have a safe pregnancy, and to have a healthy child. And we have 4 areas there. We have family planning, we have maternal and newborn care, we have immunization, and we have case management for sick children, for diarrhea and pneumonia, which are the 2 most common illnesses in most low and middle income countries. So this is the formula. Don't worry about it, but ideally, if it was perfect, it would be 100%. It's also defined in our papers. So let's start with the equiplots. And the first one I'm going to show you is, we just took a few countries. We did this analysis for many countries. I wanted to show you some that are illustrative of what's happening in the world. In these equiplots, they all start with the oldest survey. Let's look here at the green arrow. 1995 is the oldest survey we have in Colombia. Then we have one in 2000, one in 2005, and one in 2010. And then we looked at skilled birth attendant, because we think it's so important. We looked at stunting, we looked at fertility, and we looked at mortality, under 5 mortality. And if you look here for Colombia, you can see the poorest here for skilled birth attendant. They were about 60% coverage in 95, and now they're 85%. And the poorest are always well behind everybody else. This is an example of what we call bottom inequality. Bottom because the bottom group is way distanced from everybody else in the population. You see that the rich already had 100% coverage in 1990 or so, and now they still 100%. The second, third, and fourth quintiles are catching up with the rich, but the poor are lagging behind. Now, if you look at stunting, it's the opposite. Stunting is a bad thing, so the poor tend to have more than the rich. But there's also been some improvement. Right now, in Colombia, we had, 2010, we had 20% stunting in the poor. They had about 5 or 7% in the rich. So the gap is closing. The gap is closing here. The gap is closing for fertility. Again, fertility, high fertility is a characteristic of the poor. They had 5.5 kids per woman in 1995, and now they have just over 3 per woman. Again, the bottom group, the poorest group, is way far away from the rest of the population. The rich haven't changed much. They had less than 2 kids in 95, and now they have 1.5. And if we go to mortality, again, same thing. High mortality in the poor, coming down, the gap is narrowing. So if we look, and the important thing here is that when you look at a graph, what do you see? You see absolute differences, okay? The difference between the golden circle and the black circle is the absolute difference. You can divide them too, and you may have somewhat different conclusions, but if you just eyeball the graph, you're seeing the absolute differences. And in case of Colombia, these differences are narrowing down. I'm going to go more quickly through the other countries because now you already have an idea. So let's look at Egypt. Egypt is another country that's doing pretty well. Look at skilled birth attendant. It increased in the poor from 95, they had about 20% coverage, and now they're about 60. I can't get the green arrow to work now. Let's see. No problem. Just look at the graph, and you'll see that equity is improving in Egypt. A bit for stunting, something funny happening with the rich in Egypt. They have more stunting now than before. Not sure what that is. They would have to go to the country and do a specific in-depth analysis. But you look at fertility, and then you look at mortality. Huge improvement in equity and mortality. So in Egypt, the absolute inequalities are really going down quickly. But let's look at other countries too. Bangladesh. Bangladesh is very, very different. Look at the skilled birth attendant in the poor. Skilled birth attendant in the poor in Bangladesh was 0 in 1996. Okay, here's the green arrow. And now it is still very low. 10% of the poor in Bangladesh get skilled birth attendant. But the rich, it went up quite a lot. So this is top inequality. The rich are very different from the rest of the population. They are getting something that nobody else is really getting. If you look at stunting, the whole country is going down. But the inequalities are not changing very much, at least not in absolute terms. If you look at fertility, there is improved equality because the poor had 4 or 5, almost 5 children per woman, now they have 3. And if you look at mortality, also, it is also improving. So these are good news for Bangladesh mostly. not for a skilled birth attendant. That's what I meant and said. The answer to the question, are inequalities improving, depends on the indicator. So in Bangladesh, they're improving for mortality, but they're not improving much for anything else. There must be some very specific interventions here, maybe vaccinations. Diarrhea treatment is a major cause of death, and diarrhea is a major cause of death in Bangladesh. But it's actually improving quite a lot in terms of mortality, but not in terms of the other indicators. Now let's look at Rwanda. Rwanda is an interesting country that made a lot of progress recently. Had a huge genocide 20 or 30 years ago, and now it's been settling down, and we see quite a few improvements. Skilled birth attendants, much more equitable now. Stunting didn't change very much. If anything, it looks like the rich are getting better, but the poor are staying where they are. But if you go look at fertility, it's dropping among the rich. If you look at mortality, it's actually dropping among everybody. So that's a different country with a different example. Now let's look at some countries that are more complicated. Nigeria is a really complicated country for a number of reasons. There's actually two countries in one, the south and the north with all the Boko Haram, all the insurgency, all the security issues. But Nigeria is a country where there's no progress, and there are huge gaps. Look at the most recent survey here in Nigeria for 2013, skilled birth attendant. It's about 5% in the poor and 85% in the rich. So time and time again, Nigeria, we get these huge inequalities here. And they're not improving. Look at stunting, not improving. Look at fertility, not improving. Look at mortality. Oh, maybe something here. Yes, there is something here. But look at the level of mortality here. 300 per thousand. There's 30% of the children died before they reached the age of 5 years. So there's a huge amount of inequality here. So Nigeria is a country, an example of most things are not going very well. And the last one I have is Kenya. Again, Kenya is really not really going anywhere except for possibly a reduction in mortality in the very poor from 150 to 100 to just about 100 in a 5-year period from 2003 to 2008. So that's it. Different countries have different patterns. Some countries are doing better, others aren't. So if you summarize these slides on the countries, you can see that there are some good performance. Countries who are really doing well in most things. Colombia and Egypt, it's interesting that both are upper middle income countries. They are countries that really have sufficient resources, and they have made investments to bring good health care and to improve the living conditions of a large part of their populations. The intermediate group are doing well in some variables, but not in others. And I didn't show all of them here because I didn't have the time. But I did show Bangladesh and Rwanda here as examples of countries that are doing well in some indicators, not in others. And then there are the worst performers, Kenya and Nigeria, which are really not making any progress. This is the issue here is, what can we learn from these? So in the countdown to 2015, we are doing case studies in several countries to understand the reasons why they made progress or didn't make progress. So several of these countries, we have in-depth studies. We look at social inequalities. We look at trends in the economy. We look at trends in education, in water and sanitation, the social determinants of health, and then we also look at coverage. I just wanted to highlight one issue here. The fact that we are focusing on what we call proximate determinants of child health, which are like, did you get a vaccine? Did you get treatment for diarrhea? Were you delivered in a hospital? These are all very close to the outcome. They're very close to dying or to being malnourished. This fact does not mean that we don't respect and take into account the major role of the distal determinants, such as the social determinants of health. It is just that both are important. And the social determinants, wealth, education, the kind of health services you have in a country, these all influence the proximate determinants. These are all the factors, the causes of the causes. They cause the kind of access you have to different interventions that are life-saving. You know, being rich per se doesn't save lives. You know, you can put, you know, $100 bill in the pocket of an African child, and that won't save the child's life. I mean, it's only when that $100 is spent in better nutrition, in better care, in better environmental conditions, and in higher coverage with interventions. So let's look a little bit at global trends now before I conclude. And this is really new. This is a type of analysis we've only been doing for about a year or so. And we took all the 75 countries that we monitor in the countdown, and we treated each as a cluster in a multi-level analysis. And then we do trend lines. And I'm going to show you what comes out of these. So look at that. We can look at on the left here. This is the CCI, or the Composite Coverage Index I mentioned before, which has a summary of 8 interventions. And this is here, down here at the bottom is time. And then we do regression. We take hundreds of surveys in 75 countries, and we treat each country as a cluster or in a multi-level analysis, and then we do the global trends. So now, for the first time ever, we can show the trend in the richest in coverage going up a bit, but in the poorest is going up quite a lot more. So this is an important aspect that can be highlighted now. You know, many things are getting better in the world, partly as a consequence of the Millennium Development Goals and the commitments that were made by countries. And the coverage gap is definitely closing again. When you look at a graph, you usually see the absolute differences. But we have all these complicated indices that we can calculate. So we can calculate the absolute inequality using the slope index of inequality, the regression line I told you about, taking into account the 5 wealth quintiles, and it's actually getting better. But the relative inequality, the relative inequalities are also getting lower. So if we do the concentration index, it's also getting better. So according to both sets of indices, we are having improvement in coverage among the poorest are faster than among the richest. So the answer to the question here is equity improving? Yes, in general, yes, at least in terms of coverage. We can look, for example, at skilled birth attendant. Again, I said I like this variable because it's most inequitable of all variables we do. And again, this is what happened to the richest in the 75 countries we have data for, and this here is what's happening to the poorest. So it's improving faster for the poorest than the richest. So the absolute inequality is going down. The relative inequality is also going down. So again, in terms of SBA coverage or skilled birth attendants, it is improving. Obviously, we can also compare the relative and absolute inequalities. I know there's each dot here is one country, but you'll find that in most countries, they are pretty similar. So we have less inequality here, and you have less absolute and less relative, so they too are pretty correlated. There are a few exceptions. Ethiopia, here's a country that's a big exception. If you want to discuss more about Ethiopia, I'm happy to do that later. But mostly, the two types of trends have very similar answers, which is reassuring. It's not like Pelotas, where we had all this massive improvement in absolute inequality and not so much in relative inequality. But here in the world as a whole, most countries fall along this line, which means that the absolute and relative inequalities decline to a similar extent. So what drives inequality? And I'm just coming to my conclusion now. Well, obviously, as I mentioned before, it's improvement in the social determinants of health. And Brazil is a good example. We had vast improvement in inequalities. We don't have recent surveys, but as far as you can tell, between in the 90s and up to 2006 and 2007, there were marked improvements in social determinants. Nobody knows what the future holds in Brazil because our National Health Service, the SUS, is under threat now. the social determinants of health have improved for a number of years. We're not sure what's going to happen in the near future. But anyway, it's a major thing. The second point is that many countries had very specific pro-poor policies, not only in the health sector, not only by making healthcare reach the poorest. In Brazil, some examples are Saúde da Família, PSF, and Mais Médicos. These are a number of programs that have really addressed reaching the poor with healthcare, but also in other sectors, education, water and sanitation, and across sectors, such as conditional cash transfers, the Bolsa Família in Brazil. And by the way, there are lots of studies from different countries, and most of them show very clearly that cash transfer do improve equity in terms of intervention coverage. It's very, maybe not in terms of all variables that we would like to, but they're very important intervention. They're evidence-based. And the other thing that I also wanted to highlight before I finish is that for some interventions, the women and children in the richest quintile have already hit the top. You know, if you go for a skilled birth attendance in Brazil, it's 100% in the rich. So if national coverage goes up, it has to close the gap between rich and poor. Obviously, the rich cannot improve anymore. And this may be true for some of the interventions for nutritional status, for example. The rich may already be at optimal level of nutrition, so any further progress at national level means that the poor are getting better because the rich just can't get any better. Now, what is the future? And this is my last slide. 2015 is the end date for the countdown, and it's the end date for the Millennium Development Goals. But the post-2015 is seeing now the establishment of the Sustainable Development Goals, which are much more complex and much more difficult to monitor than the MDGs were. And these new goals are going to be launched in a couple of weeks' time, actually in 1 week's time at the UN, at the General Assembly. And what I find interesting about these goals is that obviously health is one of the 17 goals. The MDGs were 8. 3 of the MDGs were related to health, MDG 4, 5, and 6. Now there are 17 goals. There's only one for health, which is SDG 3. But there's also the very, very last SDG is very interesting. It's about partnership for monitoring the goals, the whole SDG. And one of the indicators relates to data, monitoring, and accountability. And I think there's no better way to finish a series of goals like the SDGs to say that this goal is not a goal to reduce mortality or to improve, to make the environment safer or to prevent global warming, but it's a goal that says we want to increase significantly the availability of high quality, timely and reliable data disaggregated by income, gender, age, ethnic group, and so on. So this is, I have to tell you that I'm very happy to see that finally disaggregation, equity are really part of the center of the future agenda. So thank you very much.
Okay, you didn't hear the first round of clapping here, so because I didn't have my mic on, and now you'll listen again, okay? Yeah. So thank you again, Cesar. I think everybody can again and again find out how you can achieve an optimal combination of solid science with social justice concerns. That's what our colleagues at Pelotas, led by Cesar and Antonio Aloysio Barros, and also by Fernando Barros previously, show us very clearly. I had the opportunity, I was lucky enough to be able to listen to variations of this talk in several occasions in scientific meetings we were together. And every time I listen to these, I see these graphs and then I listen to Cesar's talks, makes me think of something else to it's always food for thought. So let me ask you a first question, Cesar, and then we open for the audience. Maria Helena Bastos says, you're brilliant, the slides are brilliant, and I'll tell you that we'll edit this conference and this debate, and in a couple of weeks we'll have it available, the video edited by our students here. Okay, so everyone who's eager to have these slides and Cesar's talk will have it as soon as possible. But Cesar, one of the things I've been thinking this time is, would you comment on the fact that you've been working with wealth quintiles? So, of course, in rich countries, the richest quintile are, in absolute terms, people are better off than the richest quintile in poor countries. So how do you reconcile this fact with the comparisons you showed us? Is there any possibility of using the same methods and trying to achieve absolute values of wealth and still have the be able to compare across countries and regions? So I'll close my mic now.
Very good question. I'm here. I'm giving this talk from Boston, and tomorrow I am meeting with an economist here because we have been struggling with this issue. Obviously, quintiles represent relative wealth, and I think they are important. You know, there are advantages of relative wealth, mainly that there's 20% in each group, a little bit more in the poor because we actually use family wealth quintiles, and the poor have more children than the rich. But typically we have 22, 23% in the poorest quintile and maybe 16, 15% in the richest quintile. They're about 20% each. They don't change in size very much. So the poorest 20% in 1990, in relative terms, they're comparable to the poorest 20% in 2015. So the groups stay with similar sizes, and that's a real advantage when you're using the comparison between rich and poor. If you use absolute numbers, absolute income, or absolute values for wealth, in many countries, people were getting richer. For example, in Brazil, the very poor became much richer between 1990 and the present. So if you use a single cutoff, such one minimum wage or less in Brazil, you have to take into account the fact that there are many fewer people now getting less than a minimum wage than there were 20 years ago. So you are comparing now a more extreme group of the tail. If you think of the bell curve of income, which is not a bell curve, by the way, you know, income is not normally distributed, but just to make it easier, if you think of the size of the poor, it will change over time. So it's a bit complicated to say mortality in below one minimum wage was so much when you had 20% of the population between one minimum wage, and compare it with the current levels when you only have 5% below one minimum wage. So the 5% are a more extreme group in the curve than the 20%. So relative, in a relative income has a real value. And it does compare the poorest 20% in Brazil with the poorest 20% in Nigeria. Obviously, the poorest 20% in Brazil are much richer than the poorest 20% in Nigeria, but they're still the poorest 20%. So there are advantages here. But having said that, and I'm told you that I'm here in Boston because we're working with some economists here to try to take countries and actually to put a dollar value to the quintiles. And then we can say a Brazilian who is at a certain level of dollar income is much better than the Nigerian who's at same level of dollar income, or vice versa. We don't know. So we are actually doing some work here with this colleague called Ginter Fink, and we will try to put a value, an absolute value there, to see how our conclusions change when we have absolute. Having said that, there are many people who are critical of wealth quintiles, are critical of asset indices for a number of reasons. Most reasons are theoretically good. But if you look at the results I've just showed you, and let me go back if you still have my slides in front of you. Look at a country like Nigeria. You say, oh no, Nigeria is very hard to measure wealth because people are, scattered all. Look at these differentials. They're huge, and they're all in expected direction. They have face validity. This is what you expect, and this is what you get. And you get that in virtually every country. Not as wide differences as in Nigeria, perhaps, but systematically, I do think asset indices and wealth quintiles are very useful. Having absolute numbers will help us understand better, but this alone is very, very efficient for equity analysis. Thank you for your question.
Yeah, okay. I have a question here, Cesar, from Instituto IMS audience. The person says, there was an Mackey plot in which exclusive breastfeeding was higher among the poorest quintiles, okay? Do you think that this would be related to the fact that the richer can buy more formula, or is it something related to the investment in education, health education?
Oh, good question. Good question. We are publishing a huge number of analyses of breastfeeding throughout the world. It's coming out in January. And we look not only at poor countries, but rich countries. And what we have is a very interesting situation. In the rich countries, like the US and Western Europe, the rich breastfeed much more than the poor, because they are aware of the benefits of breastfeeding. And these are societies where a formula has been promoted for many years as good nutrition, which is absolutely not true. And only the rich are now being conscientious that breastfeeding is better, and there are huge differences. Then, if you go to the poor countries, it's the opposite. It's the poor who breastfeed for longer, often because they're culturally breastfed for many, many years. If you go to most of Africa, virtually 100% of the kids, particularly in the poor, are breastfed for more than 1 year. And the rich can afford formula, and they think formula is modern. So it's a very interesting illustration of how information about health and perceptions about health change with the level of development. If you look at exclusive breastfeeding, the differences are, as our colleague asked, they're not very big, but the poor do breastfeed more. But if you look at who is breastfed at 12 months of age, the difference is huge. The poor breastfeed much more than the rich at 12 months of age in most countries. Not in Brazil, though. Brazil is about the same. Brazil, we're in the middle between poor and rich, and Brazil is very good at breastfeeding, by the way. It's a model country for the world in terms of breastfeeding promotion. It's really fantastic, the kind of work that is done in breastfeeding in Brazil. But it's a good illustration of how perceptions change with development. And in the poor countries, the poor breastfeed for longer. In the rich countries, it's the opposite. I don't think, answering the question, that it's particularly due to health promotion among the poor. In this paper we're publishing in January in the Lancet, the analysis that Aloysio did, we showed that the breastfeeding, exclusive breastfeeding, is actually going up fast among the rich and not among the poor, because it's a new intervention. It's being picked up by the rich first and then by the poor, at least in low and middle income countries. So there's a a nice change here, nice in a way, but also in another way, it's always the same issue. It's that the messages about health tend to reach the rich first, and then they behavior change, and then later the poor do so. We just have another study, very interesting, coming out soon on smoking during pregnancy. In Brazil, in Pelotas, with the 5 cohorts we have a huge number of data now. And we have 4 cohorts plus another study that's very similar to the cohort. So we have 5 studies. And the prevalence of smoking in pregnancy between the rich is almost 0 now. But among the poor, it didn't fall much since 1982. There was some reduction, but didn't reduce much because they're not still getting the kind of information and help they need to see during pregnancy, and the rich are getting that. So in this sense, the inequalities in smoking in Pelotas, they are getting larger in both in absolute and relative terms. So Eduardo, I hope I answered your question, but breastfeeding is a very complicated issue. It's one of the few good things that the poor do more than the rich at least in low and middle income countries.
Yeah, Annette Treisman is asking how you define exclusive breastfeeding regarding pacifiers and artificial nipples used and so on.
Okay, thank you for the question. Exclusive breastfeeding means that the child did not get anything except for breast milk. The concept is interesting because when my kids in the 70s and 80s, we gave them juices, we gave them teas. It was every pediatrician would start with foods that were not human milk. Even if the child was breastfed, they would give juices and teas starting at 2 or 3 months of age. It was common practice. And then there was a series of research works, and one of them we did here in Pelotas. And we show that even if you just give teas or juices or water, you increase the risk of diarrhea. And if in the poor families, you increase the mortality due to diarrhea. And then you also increase mortality due to pneumonia and other infections. So there was a real change, and the change was adopted in 1990. For being exclusive breastfed, all you can give the child are vitamin drops, which are not really necessary, or you can give them ORT, oral rehydration solutions. That's okay if you're exclusive breastfed. It's actually very rare. Very few children who are exclusive breastfed have diarrhea, so they don't need treatment for diarrhea. But the official definition is breast milk and nothing else except for some medicines. You can still give some medicines. That would still be exclusive breastfeeding. Now, the question about pacifiers and other types of nipples, they are not included. I mean, you can be exclusive breastfed and use a pacifier. That doesn't matter. I mean, it does matter because we don't recommend pacifiers. But you can still, according to the official definition we use in the surveys, the pacifier is not a variable that is part of the definition of exclusive breastfeeding. So the answer is yes, you can use a pacifier and be exclusive breastfed. What some research has suggested, and there's still a bit of controversy, but it's that pacifiers are not good for breastfeeding. They help because of nipple confusion. That is, a child who is suckling on the breast and suckling on a pacifier or in a baby bottle. There are different types of actions that the child has to use his or her mouth to suckle on these different kinds of nipples. And that leads to confusion. They don't breastfeed as efficiently. So that's one issue that is related to pacifiers use. But the answer is yes, you can have a pacifier and still be regarded as exclusive breastfed.
Thank you, Cesar. There is another question by Ana Ferrari. She thanks for the excellent presentation, and she would like to know what can be expected about the new resolutions of Agência Nacional de Saúde, ANS, about cesarean section rate in the country, in Brazil.
Let me, I see another question here earlier on cesareans as well. I think by Maria Elena. Yeah, this is a really interesting issue, isn't it? Because equity is about what people think is good, not about what is good. okay? Equity in adopting health behaviors. And so cesarean sections are a good example of people think it is good, so the rich do more than the poor. You know, unnecessary cesareans are bad. They increase maternal mortality, they increase newborn mortality, but people think it is good, so the rich do more than the poor. And now the poor want to do more cesarean sections as well because this is perceived as being rich, behavior. So cesareans are a good example of the fact that equity is related to perception of good things rather than the actual how good things are. And let me just open a quick example here. And it's also true for vaccines. You know, in a lot of countries, in the US here, in Europe, the rich now think vaccines are not good. They're dangerous. They cause autism, which is completely wrong. You know, there's no scientific basis. So what we're seeing in this country is that the rich are vaccinating their children now less than the poor because of their perception that not vaccinating is good. So it's a complete wrongful vision about health benefits. And it's true for cesareans, it's true for vaccines in high-income countries. But going back to the question of cesareans in Brazil, I think we're near the point of saturation now for the rich. You know, in Pelotas now it's about 90% cesarean sections in the rich. They don't have a cesarean if there's not enough time for it, because it's almost like everybody would like to have one. And when this new resolution came out very recently about the publishing the cesarean section rates in different hospitals and different professionals, I think it's a very positive change. I think the change in this will not do the job alone. The change in cesareans will happen when women come and demand cesarean section. This is a good thing. You know, I'm not saying that the cesarean are the fault of women. No, but it started with the doctors. It started in the 1970s, and then they convinced women that cesareans are the best way. They're painless, and they're not dangerous. And then women started demanding cesareans, and we have good anthropological, ethnographic studies about that. Now, what strikes me is when the list came out in Estado de São Paulo, and that was during the Abrascão Congress, we could actually download the list of obstetricians in São Paulo who work for the private insurance, for Bradesco, Unimed, and others. And I actually counted. There were 500 obstetricians in the list. 82% of them had not done a single vaginal delivery in the last year. Not one. They were 100% cesareans. 82% of private health plan obstetrician had not done a single cesarean section. I think it's useful, but I think it's also a matter of the Justice Department, you know, Ministério Público. You know, isn't that malpractice? You know, doing only cesarean section? It is malpractice. In any country of the world, it would be considered as malpractice. So shouldn't we have something that forces, that punishes doctors who do 100% cesarean sections? It's not justified. It can't be done that way. So with a lot of pressure from the population, from women, plus some help from the judiciary in Brazil, we could do something about cesarean sections. Because we are the leader in the world. Number 2 is China. China is, but it's still not 50%. Brazil is now 57% cesarean sections, according to the latest data I have from SINASC. So it is a real issue in which inequalities are going in the other way. But yet we see some very poor mothers in rural places in Brazil, or even in urban places, who go from one hospital to another until they can have a baby. It's been documented very clearly in some studies. And they still sometimes die because they lack a cesarean section. A cesarean section that was done in time, the baby would not have died, or the mother would not have died. So it's a very tricky intervention. We need about 15% cesarean section maximum, but we need them. If it's above 15%, we already know from a number of studies that it increases maternal and newborn mortality. Oh, and by the way, somebody said something about midwives. I fully agree. I fully agree. You know, we cannot have a country in which only doctors are allowed to perform deliveries, and they do a lot of C-sections. All the countries with very low mortality, if you go to some countries in Europe, you go to Netherlands, for example, they have very low C-section and very low mortality, but it's all run by midwives. Doctors are only called in when there is an emergency, and they have the basic action of delivery is done by non-doctors.
Okay, if not, Cesar, I thank you again and again, as usual. You gave us a good example of how social epidemiology, and particularly social epidemiology applied to global health, which is the core of our issues here in this course, is not about common sense. It's about complexity. And again, ok, então eu vou, em nome do grupo, agradecer a ele por telefone, por e-mail, agradecer a presença de todos. Vamos registrar as palmas de qualquer maneira.